Uh, we have one more speaker before we go for our open forum. Our next speaker is going to speak on how to manage a case of scoliosis in a patient diagnosed with fibrous dysplasia. I present to you Dr. Bienvenido Leo Antonio M. Caro. So, please.
Okay, just a disclosure. This is an adult patient with a spinal deformity and not necessarily a patient with adult spinal deformity. So good morning. So I'm presenting a case of RI, a 25-year-old female. She is a student and she has an 18-year history of losing her balance while performing activities. Apart from this, her mother would notice that the patient has a back deformity and has worsening varus deformity of both lower extremities. So they would seek consult with a traditional healer. And then they eventually consulted with our institution after consulting with several other hospitals. So for the review of systems of this patient, important to point out, she had no chest pain, palpitations, no note of any dysuria or urinary incontinence. Fortunately, the birth and maternal histories were unremarkable for this patient. Her milestones were at par with her age, and she had menarche at 12 years old. For the past medical history of this patient, apologies, she has a diagnosed case of osteogenesis imperfecta, Silence type 3. She underwent bracing upon first consult at 8 years old in our institution. She finished pamidronate therapy and is now maintained olendronate treatment. She had prophylactic pin fixation of both femurs last 2008, and unfortunately, due to an accident, she had to be revised with regards to her pin fixation on both femurs. So she is an ambulatory patient, but with her cane, she had no note of blue sclerae. She had no skin lesions, no hairy patches, no nevi on any portions of her body. And this is the focused physical examination of our patient. Not seen clearly, but this patient has prominent parietal and temporal bones on her head. You can see that there is an equal shoulder length when she would bend forward, and we see a kyphotic thoracic spine. Fortunately, she has no noted neurologic deficits, and she is normoreflexive on all extremities. So presenting the x-rays of this patient, we see scoliotic curves on the thoracic, proximal thoracic and lumbar areas. If you can see right here, there is a faint 12th rib on the right. And along with this, we see semi-segmented and non-segmented vertebra starting at the level of T10 down to the level of L2. For the lateral view of this patient, I hope you can see it. She has codfish vertebra spread throughout her thoracic and lumbar spines. And these are just the radiographs of both femurs. No note of any varus deformity, with a pin adequately placed on both the right and left femurs. So this patient actually a diagnosed case of congenital scoliosis. She has osteogenesis imperfecta type 3, and she has undergone procedures for her femurs in 2008 and 2010. So just reviewing our core textbooks and a journal presenting a patient with osteogenesis imperfecta and scoliosis. Just remember that there are 4 types for the osteogenesis imperfecta diagnosis. Don't forget your letter A and letter B subtypes for type 1 and type 4, but focusing on type 3 because this is the one applicable to our patient. These types of patients usually have deformity of the long bones, they have short stature, and usually diagnose cases of scoliosis. So reviewing the textbook, for patients with 40 to 50 degree curves and they are past their peak height velocity, they have substantial curve progression. For this patient, her initial x-rays were actually 20 and 26 degrees during her first consult in 2008. So she is indicated to undergo surgery. But the issue with patients with osteogenesis imperfecta is that most of them are porotic despite the treatment. So I found this journal, sorry, this is a case series only, in 10 patients. And 7 of those 10 patients underwent fixation with cement-augmented screws, and the outcome measures were the Cobb's angle, the translation of the apical vertebra in relation to the C7 plumb line and the CSVL, the tilt of the lowest instrumented vertebra, and the global coronal balance. So this is just a list of the patients included. And as we can see, there was a significant Cobb's angle improvement and apical vertebral tilt as well as low instrument and vertebral tilt improvements. And this is just a picture of one of the patients they cited. So as you can see, for doing surgery in patients who are osteoporotic or with poor bone stock, the screws are relatively long, they are relatively large, and most of all the levels were included in the fixation. So I think for this patient, we can probably go down the same path. And just showing the cement augmentation for the levels that wherein the screws were applied. So for this patient, moving forward, given that she's indicated for surgery, further workups would need to be done, a CT scan, an MRI, a pelvic X-ray to check for the incidence of this patient prior to surgery. And then we will have to secure cement-augmented screws in correcting the scoliosis of this patient. So, thank you.
Okay, so this part was